The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, and thank you for attending the STN monthly webinar. This session is being recorded so that it can be offered as an on-demand CE for our members. Your lines are muted, but if you have any questions during today's presentation, please type them into the question panel and we will answer them at the end of the presentation. STN is an accredited provider of continuing nursing education. To claim CE for this session, you must attend the entire session and complete the online evaluation of the presentation. If you are attending this live session, you will receive an email about 1 hour after the event with directions to complete the evaluation. Certificates will be emailed approximately 7 to 14 days after today's event. If you are viewing this session as on-demand CE, you will be able to download your certificate after completing the quiz and evaluation. Today's speaker is Kathy Crystal. Kathy is currently a process improvement nurse at a Level 1 trauma center in Michigan for the past 3 years. She is also assigned as the clinical review for the State of Michigan Collaborative and is involved in state trauma meetings. She has worked on various projects involving the geriatric population and radiological reviews. Her previous experience is working in the emergency room and intensive care unit, but she actually began her nursing career as an oncology nurse. Currently, she is pursuing a doctorate in nursing practice degree for nurse practitioner at Grand Valley State University. Her passion is focusing on the geriatric trauma population and thrives being involved in trauma process improvement projects. Please welcome Kathy Crystal.
All right. Thank you, Brian. Thank you for giving me this opportunity to present today. My focus today is on the radiological missed injuries, a collaborative approach for loop closure. I'm going to talk about how this topic even came about for our PI team, what we did with it and where we're at now. And then I'll answer some questions at the end of the webinar. But to begin, the objectives of this are to gain an understanding of how we develop this collaborative approach with radiology and provide a metric that we can follow to see if we can identify these missed injuries in a more timely manner. And then also gain knowledge about the collaborative multi-directional approach. So we want the feedback to go both ways from our trauma team to radiology and radiology back to us for that loop closure process. And to decrease radiological missed injuries with the ultimate goal of improving patient outcomes. And also have this approach be non-putative. We want to have feedback that's positive, it's a learning environment, but also develop that relationship with our radiology team. Because when I first started this project, when I first used the word missed injuries, it came back as not a great word to use, but now is more accepted by our liaisons as we had moved forward in this project. But the target audience, the main focus is for the trauma program managers, the trauma PI coordinators for this project. It's been heavily led by the PI team, but also we need collaboration from the trauma surgeons, orthopedic, neurosurgery, radiology departments, as well as even our ortho spine team throughout this project as well. Background, success of management of the polytrauma team is to identify the injuries early and accurately, and identify and follow up on radiology misreads is important for the trauma patient to delay any care or decrease hospital length of stay, etc. But trauma surgeons and consulting physicians will review the images dependent of the radiologist. Depending on where you're at our facility, we find that ortho does as well as ortho spine, neurosurgery. But oftentimes they would find these missed injuries, and then we didn't really have a good process of how to track them and how do we loop close that process. And then newly identified injuries often resulted in delayed management of time-sensitive injuries. For example, whether it was somebody who ended up needing an operative intervention as simple as a spleen or better pain management for rib fractures. Currently, there's this RAD PI system that's available. That's a more of an electronic internal system that works to try to define the percentages of missed injuries. We don't know how much that process, because overall it's usually about 3%, I think. But we wanted to know for our complex trauma patients in our population, where do we lie with this, with the missed injuries? And some more background related to literature. about almost 50% of patients that are transferred to a level 1 center from an outside hospital, the outside imaging that they receive are found to have missed injuries. And this is important too, especially for level 1, level 2 centers who receive a lot of transfers from outside hospitals, such as we do here in Grand Rapids. And 90% of those were found to be clinically significant in some of the literature as well. But then also, they can have a big impact on the patient. Like I said, it can result in longer hospital lengths of stay, readmissions to the ICU or unplanned admissions to the ICU, and even operative interventions or IR interventions as well. Given the complexity of interpretation of trauma imaging, some hospitals have dual reading processes, which is, it's costly and it's time consuming as well, but we don't have that here. So we wanted to figure out a process of what we could do to try to identify these injuries in a timely manner. I'm going to start out with a case scenario. This kind of gives you feed into how we started this whole process and then how we developed it from there. There's been a lot of changes along the way of our initial development of this process, and it's just a continuously loop of feedback and how can we make things better based on the patient cases that we identified. But first, we had a middle-aged obese man. He was in a motor vehicle crash, about 55 miles per hour. So he struck his abdomen on the steering wheel and he had positive seatbelt sign. He also had a longer extrication prior to arrival. And then he arrived to the ED trauma bay. He was resuscitated, did the primary, secondary assessments, and they brought him to the CT scanner, did the chest, abdomen, pelvis. He began to become hypotensive in the 80s, and they gave a fluid bolus in which he was responding to, and he was more of a transient responder. And then through for his CT abdomen, he was found to have a grade 1 spleen, and he also had another injury, the left posterior hip dislocation. With this, the patient, after the fluids, he seemed to be stable. They didn't think he needed ICU, so they brought him to an ED room where they did further care. And then in the ED room, they actually had ortho come down and ortho sedated the patient to reduce that left hip. And then he was in the ED for about 3 hours. And in that time, he continuously had soft blood pressures, 80s, 90s, he's hypotensive, and also requiring a non-rebreather, which is something he did not require when he was in the trauma bay previously. It was about an hour after the sedation that he still continued to have low blood pressures and non-rebreather, in which he was transferred to a general medical floor. And when he arrived to the floor, he had, again, his blood pressures were in the 90s, he was tachy in the 120s, and he was still requiring a non-rebreather at 15 liters. So at this time, when I continue to talk through this case, you can probably identify a lot of PI issues that are popping in your head, but we'll talk about that at the end of this case review. But the nurse continued to call the team overnight, because this ended up being like evening into the nighttime when this patient was transferred up to the floor. And he got about 2.5 liters of fluid. He would respond, and then his blood pressure would go back down again. As you can see here, his labs, his lactic acid was 5.1, went up to 6.8. As they continued to check his labs, his CK went up to 3,500. His potassium went up to 6.6. His blood sugar was in the 330s. They treated it. At one point in the documentation, they actually were thinking he was having some metabolic issues due to diabetes, is what they were thinking. But then hemoglobin was 14.2, and then dropped on admission was 14.2 and dropped down to 11.1 throughout the night. And then the trauma resident that was on during the night did a bedside EFAST and documented as negative. And one concern with that too is this patient was quite obese, so was the body habitus a barrier in this exam? And then by the AM, a new team came on. They did the morning labs. The patient's hemoglobin dropped down to 7.5. And again, he was at 14.2 when he initially arrived. And then his lactic acid jumped up to 17.1, and his base deficit was -21. So as you can see, this patient is pretty sick. They quickly transferred him to the ICU to resuscitate him and started the mass transfusion protocol, where he got several units of blood. I didn't write down here how many units he had, but I know he had several to resuscitate him. And then they emergently brought him to the OR for an XLAP, splenectomy, lysis of adhesions. And they ended up finding about 3.5 liters of blood in his abdomen. So with that, we thought, well, they did the EFAST in the night and identified that there was no blood in his belly, but he had a large body habitus, but yet this is a large amount of blood in his belly, so why wasn't it seen on an exam? But this case was more of a Swiss cheese effect, was saying that we had the misread on the radiology report for the CT abdomen that said a spleen 1, which actually was a spleen 3 to spleen 4 later on after review with the radiologist. And then also being in the ED, the patient had some sedation, so they kept contributing his hypotension and oxygen needs related to the sedation, but that continued onto the floor. The nurse was pretty diligent in calling the team, but they contributed it to, oh, he was responding to the fluids, and they also thought there was some issues with his blood sugar along the way there. And then with that, we had reviewed this case from beginning to end to figure out what we could do to improve and prevent this happening in the future. But again, the patient was admitted to a general medical floor from an ED room and from the ED, and he required ICU. He should have gone to the ICU with his hypotension and his oxygen needs. So there was a barrier there as well. And then the RN on the general medical floor called the trauma service several times, as I said, and reported to them that the patient's lactic acid was elevated and the blood pressures were in the 90s, but they continued just to order fluids. And with that too, with the radiology report of a grade 1 spleen, it was pulled over into the H&P, and so that H&P with the copy forward, that spleen 1 has been reported throughout the patient's chart and progress notes and such as well. And so opportunities for improvement for this case were many, as I have pointed out, and many of you probably could point out yourself as I went through this case. But the question was, did the ED trauma team have some sort of handoff discussion about this patient after the patient was brought from the trauma bay to the CAT scan to the ED room? And one thing we found out with this is that the ED nurses knew somewhat that the patient was with the trauma service, but they didn't know really how to find the phone number to call the team, and they're more comfortable with contacting the ED physicians, so that's who they would go to if they had a concern. So knowing that this patient was going to be admitted, they thought going to the ED physician was best, but they also didn't realize the trauma team should be aware of the decline of the patient in order to make further decisions about where they should be placed in the hospital and what other interventions they'd want at that time, or further testing. And then also no communication with the trauma team about the patient condition, as I just said, was that we don't know if the ED physician, in review of this, there was no communication to the trauma team that the patient had declined and the ED was hypotensive, requiring more fluids, more oxygen. And then documentation of communication between the team members did not occur. So just sitting down and reviewing this chart, we didn't see in the documentation anywhere where there had been that communication, where the trauma surgeon or trauma resident reported that they communicated to the ED team, or that the ED team communicated back to our trauma team about this changing care for this patient. That we found out the communication did not occur after interviewing the team that was involved, the RN and the physicians. And then the radiological missed injury resulted in the delay of the operative intervention. We also discussed that maybe this patient could have had an IR intervention versus an OR if it would have been caught earlier. So the trickle effect, the Swiss cheese effect of this all started with they're thinking this was only a grade 1 spleen, so they weren't as tentative to this patient as they went through their ED stay, and also throughout that night thinking that this patient wouldn't have a decline because they only have a grade 1. So through this process, we also had identified other cases that had missed injuries on a radiology report, such as whether it was a hand fracture or a rib fracture, diaphragmatic injury, spinal fracture. So what we had decided is we need to figure out a way to track these, because we know that, as I said, neurosurgery, ortho spine, all of them are commonly reviewing their images, finding missed injuries, but how do we report these, and give that feedback to radiology so we can improve this process and prevent this for future cases. And another common thing that we'd find is the trauma registrar would go to code a case, and ortho would say that there's this injury, but the radiology report would not say that injury existed on the scan or the x-ray. And so we'd have to go back and try to verify with radiology, is this injury there? And that's how we would also find other cases. But we want this to be a more concurrent process and prevent that from happening. So what we did is I worked with the trauma PI team and the trauma medical director and trauma program manager to develop this tool. We want this tool to be utilized by the trauma physicians, the residents, and even our emergency general surgery team, our surgical ICU team, and even ortho spine. We shared that with them. And for our trauma team, our trauma physicians also work with emergency general surgery and surgical ICU. So we thought putting those all three together was important because, as many of us know, our trauma patients can also end up in the surgical ICU. So this is the tool that we developed. We try to make it very simple and straightforward because, as we know, the team's very busy. So we want them to easily just be able to jot down the information that we need so that the PI team can look further into the case. But we definitely want a patient name, their first and last name, and their MRN number so we can easily locate them, what radiology exam was ordered. And this is also important too because it helps us to know, are we finding more of a theme with missed injuries on chest x-rays, on chest CTs, chest abdomens, on C-spines. And the date of the exam is important too because we know that patients will have several chest x-rays throughout their stay or different CTs. So we want to know when was that x-ray that you're looking at, because sometimes when we're looking at that in the back end, it's hard to tell, but the chest x-ray on day 2 might have found the injury and day 1 didn't. So it allows us to compare the two when we give the feedback to the radiologist. And we put the FAST exam on here just because of the case that I presented to you. And also because we've had cases where there may be some discrepancy between what was documented as a final result for the FAST exam versus what was found on the CT scan. And this helps us to provide feedback in that area as well. And then the discrepancy, so we want to determine, was there a change in the patient care? Whether, like I said earlier, whether as simple as we needed a consult ortho spine for a clavicle fracture, they needed a pain management for rib fracture, more pain management or more control or more focus on pulmonary hygiene, or was it an operative intervention, or was it even death? So those are the things that we want to figure out and give that feedback to radiology as this is what the change of care was by this missed injury, so they can understand it from our viewpoint as well. And then discrepancy of radiology, like I said, change in patient care. And the primary service, I put trauma service on there, the surgical ICU, and emergency general surgery. And like I said, I put all three of them on there because our physicians for trauma work for all three services. So we want them to have some kind of reporting tool that they can bring back to us. And then, so from this, the trauma PI team worked closely with a couple radiologists, specifically our radiology liaison, who's phenomenal, the trauma medical director, and some feedback from the trauma attendings to figure out how do we define this process to make it have loop closure and prevent future cases. One of the things that came from this is that we found that there's many different radiologists. Our radiologists are huge and they read for many different hospitals. So how do there's a variety of them that will read, they could read for trauma and not read for trauma again for a month. What happened throughout this process is the radiology liaison worked really hard to get just a select group, like 5 radiologists or so, that will just read for trauma. So they get used to reading for these complex cases. For example, we had a couple patients that had a diaphragmatic injury that was missed, and those were cases that weren't too far apart. But how can we prevent this? So just having those same radiologists read and knowing that's a very important area to look for on the scans. But also the liaison worked hard to develop that template so that when the radiologist reads the exam or the scan, but they also will report no diaphragmatic injury. Because in those cases, the diaphragm wasn't even mentioned at all. So did they look at it closely or not? So just paying more attention to that. But then significant findings that are identified are communicated directly to the trauma surgeon. And this is another point too with diaphragmatic injury that was missed initially on a scan. The patient had another scan, then had a third scan where it was finally identified. But with that, the radiologist called the trauma resident. And then he also put that in his report that he reported the missed injury or the critical finding to the trauma resident. But then the resident did not report this back to the team, and that caused, and the addendum was somewhat buried in that whole report and was missed by the rest of the team. So again, it was a sort of a Swiss cheese effect of reading the report thoroughly, but also getting the message to the rest of the team by the trauma resident. But from that, we had identified that the trauma attending should be the one that should be called on critical findings directly to their hospital phone to prevent this miscommunication, and also just leave out that extra step of having to phone somebody to phone somebody. And then also having the trauma surgeon review all images independently. Obviously, this is, as I say, as soon as able, because we know the trauma services are very, very busy, especially in the summer months. So we expect them to do that, try to do that in a timely manner to look for these missed injuries so they can be concurrent reviews to the radiologist and give feedback and also prevent any delays in care for the patient. And then the trauma surgeon reviews images with the radiologist. So for example, if the trauma surgeon's taking care of a patient, they go review the images and they see something on there that they think there's another fracture, or the spleen is actually a 3 instead of a 1, they can actually go down to where the reading radiologist is and discuss that with them. And they're available 24 hours a day in-house so that they can determine what is the appropriate injury or diagnosis for this patient and make appropriate follow-up for that or further testing if needed. And then the trauma surgeon documents any missed injuries on that reporting tool that I showed you. So that tool is made available and accessible where the physicians and residents typically sit in their area in the ICU where they would document, or in the physician's sleep room where they may also sit and document as well. And then the trauma PI nurse, the nurses will go and check. It's actually in a folder in the area where they sit. So the trauma PI nurses will regularly check that folder to determine if there's any missed injuries reported, and then bring that back to the trauma radiology liaison. And with that process, also the PI nurse vets through that to determine what is that true issue here. If there is a missed rib fracture, what report is it on, and sending that exact date and time of the x-ray to the patient or to the radiology liaison through an email, giving the patient identifiers so they can easily identify the case, and it's sending them information about what the change of care was for that patient as well. And then the radiology liaison reviews that patient case and confirms whether that radiologic abnormality is present. And sometimes that liaison will even consult with specialty radiologists such as neurosurgery, if that's a little bit out of his comfort zone, just to get another set of eyes on it to identify whether it is a missed injury, or if there's even other missed injuries that are present that weren't even sent to him as well. And then the radiology liaison will send back an email verifying that the injury was present, and then the trauma PI nurse will put in that RAD-MIS, we call it RAD-MIS, injury into our registry to track. We'll put the occurrence, because sometimes we've had patients who've had more than one missed injury, and then also how the process occurred, what was the communication, and also putting the email into the registry for later review if needed. And then also that helps us so that if we wanted to, we could say for all of 2017, we want to pull all the RAD-MIS cases, and we want to identify what scans they were, and what were the injuries. Was there a time of year that was they were missed more, such as maybe in the summer or and things like that, so we can track and trend different variables. Then also the trauma radiology liaison provides feedback to the trauma team when there's a false positive finding that's presented. For example, if we get one of the reports from the radiology or the trauma attending or residents that think that the patient has 2 through 6 rib fractures on the left side, then we'll send that over. I'll send that over to the radiology liaison, and then he says, no, these fractures aren't present. Then we also want to do that loop closure back to the reporting resident attending to make sure that they know that that injury really isn't present and what did they see, and also allow them to give that time to communicate back with the radiology liaison to say, what are you seeing that I'm not, or vice versa. This also helps too with documentation, because also, as I said earlier, if you have a trauma surgeon that's reporting these rib fractures, but then there's no report of it on the radiology report, that makes it difficult to determine how should the trauma registrars be coding this injury. And if the radiologist said that's not present, but it's coded all over in the chart, then that's a little concerning, and we want to get an accurate ISS for this population. The missed injuries are documented in electronic internal peer review system. So the radiology liaison puts this into a peer review system that's separate from their performance review system. And it enables the original radiologist to go in, review that missed injury, and also rebuke it as well, and give feedback on what they found or what they're not seeing or why it's something else. And then with that too, in the past, I've actually had trauma or radiologists call me and apologize and say they're going to improve or update the report and add an addendum. And that adds another whole area as well, is that with the new findings, we need to put an addendum in as well so that we can accurately code and it makes sense with the documentation that's in the chart by the physicians. So normally that addendum was blended in right with the rest of the report, and it was at the top, so it was easily missed because it blended in with a bunch of other information that was documented at the top of that report. So what we found, because we had that missed injury with the diaphragmatic injury that was missed on a patient, and we found that the addendum was part of the Swiss cheese effect of that, why it was missed, because it wasn't easily identifiable in the report. So now the addendum goes at the bottom of the report, and it's highlighted or bolded, so it stands out for the resident and the attending. Because when the resident or attending goes and does their tertiary exam within 24 hours, they should be reviewing all of the radiology exams reports with that. So having that addendum stick out so they can see it a little easier. And then also cases that are significant or notable cases are reviewed in the monthly trauma committee meeting. And these are presented to all the specialty services that are involved as well. But through that has also opened up their eyes to realize that this has been something that we have had identified. So bringing that feedback to radiology has been helpful for their own education and feedback. And then also we have recently gotten a new radiology liaison, and he was at our most recent meeting this month, and through this he had reported that he didn't realize how important identifying all the rib fractures are. And it is for coding purposes, and also if you have a geriatric patient that has a number of rib fractures and they're not all identified, we know that as they have more rib fractures, their mortality rate goes up. So that was a big eye-opener for him and some education that he can bring back to his team as well. But also, through this, the significant missed injuries are also reviewed at the radiology morbidity and mortality. And in the beginning, the liaison actually reported and reviewed every single missed injury case at the M&M review for radiology. But then more so lately, it's been more of the significant cases because the rib fractures have gone through several times with the education going back. And then the radiology team can review additional cases on a study share file. So they have this study share file that's private and HIPAA protected, that the other team members after the M&M could go in and review those cases for educational purposes and see how would they have looked at that case, or how can it prevent them from missing one of those cases in the future. And then the overall goal of this is to have a two-way feedback process, as I have mentioned a couple of times, where it's the key to success. We really want, in the beginning, we didn't really want to feel the radiologist to feel pressured or that we were just hawk-eyeing them throughout this process, but that we really wanted to work with them as a team, as a professional team, to figure out what can we do to make this better and give the best care for our trauma patients. So it's a process where we want feedback from them as well. What are the barriers for them? For example, one of the things we found is that we'll have a patient come in with an MVC and they'll do the whole pan scan, and the radiologist is trying to figure out, what should I really be focusing on here? So what was done was that the radiologists were faxed a sheet that would describe the patient, what mechanism they had, where the trauma surgeon was thinking they were injured, was it their, did they have seatbelt sign, those sort of things, where was their bruising, to help assist the radiologist to where they should focus with these patients as they're reading the exams. Obviously, we don't want them to miss anything else, but to help them key in on what we're looking for on the outside, because they're not at the patient's bedside. And missed injuries, we want to report them to the reading, they're reported to the reading radiologist in order to make this process work, and they need to get that feedback as well so they can learn from it and also prevent that from happening in the future. And also, like I said too, that if a reading radiologist doesn't agree with it, do we get another radiologist involved as well, or is it just not there? And so giving that feedback to the trauma team as well. So the design of this was more of a quality improvement initiative, and the goal was to reduce missed radiologic injuries. They said multiple times this is a collaborative approach between the trauma team and radiology, the trauma PI team, but also we don't want to leave out neurosurgeon, ortho spine, ortho, all of them as well, because there's missed injuries in those from those services as well. But this collaborative approach has really developed a nice relationship with the radiology department. But what we did was we looked at, from we started this, the first case that we identified was in August 26, 2015. And we went all the way to May 7, 17 for this data sample here. And there, in that time frame, there was about 1,567 trauma patients that were admitted to the trauma service. So with that, we wanted to identify how many missed injuries did we find in that population. And we found that there's 77 imaging studies that had missed radiologic injuries. And that's just us finding them. And that's the question that's continuously out there throughout this PI process is, we know that the trauma surgeon's residents have not reviewed every single case. We would love a dual reading process. We just don't have that right now. We don't have, it's costly. So there might be some out there. We're hoping not major, but we're hoping that we are finding the majority of them. We did exclude about 14 of the cases for this further review that we nailed down on. Of the voice recognition errors, for example, we had one that said intraperineum hemorrhage instead of intraparenchymal hemorrhage. So we excluded those kind of voice recognitions for right now, but we still collect those and provide feedback to the liaison for an addendum to be added, because the last thing we want to do is have a patient request their records and it says words like that and they're Googling it and super confused. But we also excluded 12 additional cases that were pediatric cases or non-trauma service, such as ortho, just different emergency general surgery, because we had a few of those cases from them as well. Then final inclusion, we found that there was 49 patients in that time frame with 51 different images that were missed injuries over that 20-month period. And the two patients that had the two images that were missed were the diaphragmatic injury cases. To nail down a little further, we had about 63% of those missed injuries were in the males, which we know that usually the male population is the higher trauma population. But MVCs were 61% of the population, complex injuries. And then average age was about 43. And the injury severity score was 20.6. So we wanted to dig deeper to see what are the exams that are done that there's more common missed injuries on in this patient population. And we found that the CT of the thorax, the chest x-rays, the abdomens were the most common one. So we put a graph together here, and you can see here that the CT thorax was one of the more common ones. Abdomen pelvis had about 9. Chest x-ray had about 8, which chest x-ray, a lot of them were the missed rib fractures that we found. And then also CT spine had about 7. So, and you can see there's hand, wrist, pelvis, femur, foot, and knee. So we found missed injuries on a plethora of different x-ray and CT exams overall. And we also wanted to say how many patients were had a change in care affected by this missed injury that was identified later. And we found that almost 61% of this, the N being 31, had missed injury resulting in a change of care. And again, that includes whether the patient had to go to OR, whether they just needed a simple consult with a sling, went back to the ICU or unplanned admission to the ICU, whether they needed more pulmonary hygiene with pain control for these rib fractures. And we know clinically the physicians can go and assess these patients and feel tenderness at the ribs are well, but it's also important for coding for these patients to get accurate ISS. And then the trauma surgeon, we also looked further, who was the most common physician to identify missed injuries? The trauma surgeon, and part of that probably too was this, we are on high alert and really paying close attention to this. Bringing it forward in our committee meetings, where ortho and ortho spine and neurosurgeon, all of them are involved as well, but the trauma surgeons were really diligent on trying to review all these images to find these missed injuries. And through collaboration between radiology and the trauma surgeons, we compared the time frame from January to May 2016 to January to May 2017. And we found that there was a decline in the missed injuries. Obviously, a caveat could be that were they not looking at them and finding them as much as they were the year previous, but we really bring this topic up and this PI process up in every orientation that we have with residents and committee meetings, so we're really trying to keep it on high alert continuously, even though it started way back in 2015. And here's a graph of the different physicians and how they identified. So trauma surgeon identified over 25 of them. The ortho surgeon was another one that identified many of them, but neurosurgeon as well. Even ortho maxillofacial surgeons did, plastics, and we even had some where the radiologist found it, where, for example, we send them out questioning whether an injury exists, and they come back with, yes, that injury exists, but also this injury was present as well. And that's another whole process where that's loop closure into that, giving that feedback to the trauma team, where the radiologist calls the team and let them know that injury was missed as well. We want this process to be concurrent. That's best for the patient, best for timely care, and best outcomes for the patient. So the current solidify the communication with the radiology team, knowing that the trauma residents can go right down to the radiologist that's reading the exams, review that with them. They all go down for wet reads initially after the patient is done with the scans. But what about that final report? Is there something that's different between the wet read and the final report? And having the radiologist inform the team ASAP, but also making sure that if the team does have questions back, that the radiologist is open for those questions and available. Making sure that the process is very simple, because we know that the team is very busy, so we want the reporting tool to be something that they could jot down quickly off their notes. It's non-punitive. We don't want anybody to be punished by this. It's just providing feedback and more of loop closure and education and preventing cases from happening in the future. and making it just easily accessible. Like I said, we put it in the area, put this tool close to the computers where they document. So if they just want to reach up and grab it and write it on there and put it back, it's easy for them. And also making an expectation that the trauma surgeons review all images is important. We know they're not the radiologists, but also making it, and it's been education for them back as well as learning how to look at these exams even more. And then the radiology liaison is committed to the trauma service. He has been phenomenal. Without his collaboration, this project really could not have moved forward. He's done a lot of the back work with his team. He's been very positive in providing the feedback to the radiologist so they're accepting. He's just developed other processes from this, like making sure the addendums at the bottom of the report, really only getting a defined handful of radiologists that will read for trauma. That was huge in this project, and we could not have done that without him. But also bringing the radiology missed injuries to the M&M reviews was also new for that service, and also could have been a little unsettling, but have been very open about it, and also have learned a lot from it. And having the radiologists are accountable to electronically review the missed cases. So oftentimes the liaison would face-to-face contact if able, but they're not often always even in the same location because they read at many different hospitals or on the same shift. So having that electronic system, that making sure they're going in and reviewing it and providing the feedback, knowing that they understood what was missed or was not missed, and giving that feedback as well. Then also having the metrics, as I said, like allowing us to go in and say what scans are being missed most commonly, what is there a time of day, is there a certain radiologist? So having those metrics, he's able to go back into that peer review system and monitor that as well. But also on our end, when we put that into our registry, can we track that as well? If we're consistently always seeing that it's the CT thorax and they're always missing this, these rib fractures, and it's always in the month of July, what can we do to help them out? But the goal is to maintain this consistent effort to minimize the missed injuries. We want to keep this on the radar. We want to, our goal would to have a dual process. That's something we would like in the future, but just not possible at this point. So since we don't have that, what can we do in the meantime? And as I said, we have this audit filter that's maintained in our registry to track. So and also monthly, I'll send the liaison the missed injuries for the month so he can track those as well and figure out which ones he wants to present at their morbidity and mortality meeting. And just have this continuous communication and collaboration with the radiology team. It's so good right now that we don't want to say it's good and give up on it. We want to keep it there. Some learning outcomes from this PI process is, and for all of you, is to try to utilize the information to assess what is your current state. If your registrar comes up to you and says, I found that this patient has all these rib fractures that are reported by the trauma surgeon, but the radiologist doesn't report this at all, how do you follow up on that? What kind of relationship do you have with your radiologist? And really having a trauma PI coordinator spearhead this project, as we know that trauma physicians and residents are very, very busy at the bedside taking care of the patients. We don't want this to be put aside because time goes by quickly. We really want someone to spearhead this, navigate it, and keep the initiative going, letting the team know that we're still monitoring this process, even though it's been over 2 years, it's been almost 3 years. Investigate opportunities for the collaborative approach. So how can you collaborate with your radiology team? Who is your liaison? Who else can you collaborate with? Whether it would be other specialty services such as orthospine, if you're finding a lot of missed injuries with neurosurgery, how do you collaborate with them? Identify an action plan, make it comprehensive, and also make sure that you want it multi-directional, like I've said. You want multiple disciplines involved, but you want to be able to give feedback, but also be receptive of that feedback for your educational purposes as well, and to build that relationship. And then again, recognize the importance of gauging liaisons. to achieve that loop closure. Because if we did not have our liaison involved, we would never have been able to move forward with this project. And at the beginning, we would intermittently just send him questions about missed injuries, and he would give feedback, but then we did nothing else with them really, and oftentimes didn't even add addendums to the report, which can cause confusion with coding. So really having that loop closure process and making change on top of change. Because, for example, like I said, we've made change where we had to change how our addendum looks on our report. How many radiologists are reading for the trauma service patients because they're so complex. And I can see more, and adding the template to make sure they're really focusing on the diaphragmatic area for trauma patient cases on the exams as well, and not leaving that out that it's present or not. So overall, this has been a great project. I see that there's still a lot of opportunities in the future, and it's hard to know if we've not identified them all because we don't have the dual process, but that would definitely be a goal in the future. And here's some references here, and now I am open for questions.
Great. Thank you, Kathy. Let's go to the questions. First question is, which electronic medical record are you using? Is the lack of documentation related to EMR?
Okay, that's a good question because we actually, when I started this PI process, we had Cerner, and then last fall and now we are in Epic. And so it hasn't really been dependent on what EHR we've been using because we're still finding them. It's, yeah, that hasn't been a hinder for us per se.
Okay. Do you have a reference tool for radiologists beyond the AAST injury scoring scale for organ injury grading to assist them with the grading solid organ injuries?
We have actually met with our liaison and provided him the coding injury, like the coding injury dictionary, like provided him with the details of it and what we're looking for more clarity. And we try to, and we allow him to disseminate that information as he sees best for which area of radiology, because we've had questions with neuro injuries, with brain injuries and needing measurements and stuff. So we provided him what we needed with those measurements, and he reports it to the neuro radiologist in order to get more accurate coding. So we do share that information with them when we find that's important as well. And they're receptive of it, and it's actually commonly an eye-opener for them. And them knowing that it helps us with our coding and is very beneficial overall for both sides too. So, yeah.
Next question, how does the radiologist know who to contact with a missed injury when the e-ordering provider may be different than the MD care provider?
They actually, with our team, we had required them to put a note actually in the order to who to contact with the phone number. That's a very good question because that was what was questioned before, because the radiologists actually have the trauma attending and trauma residents phone numbers posted above their desk where they're reading, but we commonly would find that they were looking just at the trauma resident's phone number. So what we have required the team to do when they're ordering is to actually put who they need to contact and what phone number right in the order.
Great. Next question, does your radiology department independently track their missed injury rate?
They do, and it's through the radiology PI, like their PI electronic process. There was also, in some meetings, they discussed how they'll do spot checks intermittently, but that's very varied on how much time they have to do that. So it's more so of the common electronic process that's available across the U.S. that they use to identify those injuries. And that's why we wanted to do this process, to have our own eyes on it, to really see what's out there within our own department and our own patient population.
Okay. Next question, how many trauma PI coordinators do you have?
That's a great question. I feel very fortunate because we actually have 3, but we're most recently down to 2, with one that comes 1 day a week, a third one that comes 1 day a week. But with that is what has actually helped me be able to spearhead this project too, is because I do have the bandwidth with the PI team to be able to do that. But yes, that's a great question, because I know there's some hospitals out there that only have the trauma medical director and registrar and maybe one PI nurse. So, but I felt like once I got this process up and running, it's actually not too time consuming with it.
Thank you. Next question. Is this coding injury dictionary the NTDB data dictionary?
Yes. Yes. Yes, it is.
Next question. Did you find their overall missed read rate higher or lower than those found by trauma?
As actually, because it's hard to say because we don't have the dual reading process for, and I'm assuming they're thinking that what we found compared to what the RadPI electronic system finds, and they were pretty equatable, but it's hard to say because we're not doing the dual reading process how many there really are. But our whole quality project with this was to what do you do with them and how do you prevent them in the future, because with the RadPI process, you get a percentage, but you don't really know what patient population is that really hitting, and is it your patient, and what are you going to do with that missed injury in the future, or to prevent it from occurring in the future. So.
Okay. Do you complete 100% images reviewed for missed injury?
Do we complete 100% missed
Image.
Reread that.
Do you complete 100% images reviewed for missed injury? I think it's 100% of the images reviewed for missed injury.
Do we review 100% of them?
Yeah.
So that's where, that would be where the dual process would come in, where we would love to have a radiologist read it, and then a second radiologist go back behind them and read it. I've had talks with that with our liaison, but it's just not possible right now with the bandwidth and the cost and such. But something that definitely would be ideal, and out there in literature says is ideal. But with us, we have the radiologist reads it, and then we also have our trauma surgeons or specialty teams also try to review all those imaging as well. And as I said, it's difficult when you have really heavy load of patients to be able to review every single of them, but that is an expectation for the team to do that.
On your tracking tool under primary service involved, what does EJS represent?
Yep, that is our emergency general surgery, and that is on there because our trauma surgeons also go from service to service depending on the day or the week. They could be a trauma surgeon 1 week, emergency general surgeon the next week, and then surgical ICU physician the next week. So we wanted to keep, because it's all one team, we wanted to include all of them. Yep.
Great. Well, Kathy, that is all the questions we have for today. I want to thank you for presenting. We're getting some good responses back already. Just a reminder for those attending live, you will receive an email with a link to the evaluation about an hour after this broadcast, and then your certificate for continuing education credit will be emailed to you along with the slides within 7 to 14 business days. Thank you all very much for attending, and have a great day.
All right, thank you.